Hi, this is David, and here I'm going to talk about leukocyte extravasation. And this clip is really geared for the medical student who's studying inflammation. And this talk is based on the Robbins textbook, really. And one of the stories about leukocyte extravasation or about inflammation, I think Robin tells a story extremely beautifully. And so I'm impelled to retell the story with my own spin, because after all, what's a pathologist if not the narrator or storyteller of disease to the hospital? And this story is really told very nicely in Robin, so why am I retelling it? And the answer is, well, firstly, it never hurts to have multiplicity of information, and some students absorb things in different ways and with different tellings. And also, I myself enjoy the story and therefore enjoy telling it. And at one point my brother told me about a book by Borges that I never wrote, called The Man Who Wrote Don Quixote de la Mancha, which was somebody who was so in love with Cervantes' book Don Quixote that he rewrote the book himself as though it was his own. And so he didn't intend to plagiarize the book. He had internalized it and loved it so much that he felt that he was writing the book, but he only rewrote Cervantes' book. So I don't think that there's any harm in retelling. And so here's yet another retelling of the story of leukocyte extravasation with my own spin and hopefully my own warmth. And maybe this will engage the imagination of even one medical student. That would be great for me. So we know that white blood cells, or leukocytes, are very important for any inflammatory reaction. But how do they get out of the blood and into the site of injury? So Robin's textbook divides this process into several steps. So we have these imagined neutrophils. I'll pick on neutrophils as my leukocyte today. And here you have your neutrophils, and they're flowing in the blood, but the blood is flowing quite quickly. And how are they going to get to the site of injury? Let's say the site of injury is here. So Robin says, conceptually, let's think of three phases. Phase one is to get these guys to attach to the endothelium, to the lining of the blood vessel. Here, I'll show you I'll color the endothelium in red. The second phase, once they've attached, he calls transmigration, and another word that's used in the text is diapedesis. And that's sort of changing the shape and getting the neutrophils to crawl out, because there's pretty tight junctions between these endothelial cells. You don't want your blood vessels too leaky in the healthy state, and yet you've got to get your white blood cells out. And so there's ways that these white blood cells, or leukocytes, talk to the endothelial cells. They change their shape through reorganization of their cytoskeleton. They manage to change their shape like, well, it always makes me think of that old TV show Barbapapa, but if anyone catches that reference. So they change their shape in this Barbapapa fashion. They sort of squeeze out, and then they get out past the basement membrane, which is another story. And then the last phase, so phase two, this sort of transmigration, this squeezing through the border, the way my cats get out of fences. And if my neighbor's listening, my cats never get out of fences. And then in phase three, these extravascular leukocytes will then migrate to the site of injury. But the phase that I really want to talk about is this phase one, this attachment. And that's what I'm going to dedicate this talk to. So continuing on in our leukocyte extravasation extravaganza, Robbins, as we said, speaks of three phases that we showed pictorially: the luminal phase, the transmigrational phase, and the migrating phase, which is really the same as these white blood cells getting stuck in the luminal phase inside the vessel, getting out, which is the transmigration phase or the diapedesis, and then getting to the site of the disease, which is the migrational phase. And we said that we were here most interested in the getting stuck phase, how the cells get stuck to the vessel wall. And even this Robin subdivides. And Robin subdivides this into three phases, the getting stuck, or the luminal phase, into three phases. And he calls those margination, rolling, and adhesion. And that's what we'll discuss. So just before I proceed any further, I'm just going to mention a central tenet of Robin, just to be kosher to the Robin book. And Robin mentions how in inflammation, you have your capillary with your Starling forces. I'm not going to go into this too much detail. You have your arterial side and your venous side, even of your capillary, because you have your little arterioles and then your little venules and the capillaries in the middle. And Robin points out that normally, in normal physiology, usually you have a certain amount of fluid that comes in here at that leaks out at the arterial end because the pressures are higher, and then a certain amount of fluid that comes back at the venous side of the capillaries because the pressures drop, and ultimately they balance, and so that or more or less balance, so that you don't have too much leakage of fluid into the extracellular environment. However, in the context of inflammation, several things happen. One is that you get this relative dilatation of the arterioles, so the fluid is coming in with more pressure from the arterial side. And the other thing is that the capillaries become leaky, so the oncotic drive back, because you're losing albumin and protein into the extracellular environment, so the oncotic drive of fluid to come back is less. And you don't need to know the details for this particular lecture, but the main point is what that does is it increases the out, and in a sense also decreases the back. This because of the oncotic drive is no longer so much there, and this because the hydrostatic forces are more in favor of out, and so that you have this leakage of fluid and proteins out of your blood vessels. And so what you get is hemoconcentration, because now your red cells and your white cells in your vessels are more concentrated, so you have hemoconcentration and albumin and protein depletion and loss into the extracellular environment. So I've shown my red cells and my white cells in red and white, and then my albumin, obviously not to scale, and my proteins not to scale in green, and you see that you have loss of your proteins to the extracellular environment, and also your red blood cells and white blood cell constituents also become more concentrated because the loss of fluids into the environment. So that increases the overall viscosity because it's more cellular. It increases the viscosity of your luminal blood, and that'll decrease the flow rate of the luminal blood. And because of your flow rate, or your Q, your flow rate is low, the blood is sort of sticking around. It's flowing slower through the vessel, and that's stasis. And that's what makes inflamed tissue look red. And even very prettily, Robbins point out that that's what the ancient Roman writer Celsus described as one of the cardinal features of inflammation, that he called rubor, or redness, and that's because of this stasis. And the stasis is in turn caused by the decreased flow rate that has something to do with the slower flow, that has something to do with the increased viscosity because of the hemoconcentration. So I just wanted to mention that. So now back to our story. Part one of how the white blood cells get out is the getting stuck part. And that's what Robin calls margination. The first phase of that is margination. What's margination? In order to really understand that, and this is quite pretty, it requires a little bit of a descriptive appreciation of fluid mechanics. So if fluid is flowing in a tube, so imagine this is a given flow rate, the fluid shear stress is highest at the wall. The drag, or the shear stress, is highest at the wall, and then it decreases toward the center. And in laminar flow, it usually is a parabolic type of distribution, so that your shear force is lowest here, and therefore your velocity is highest here, and your shear force is very high here and very high here, so much so that by Poiseuille's law your velocity can actually be zero. But the main thing that I want to say is that when you have a relatively high flow rate, you have relatively high shear stress at the periphery. What that does is it tends to strip any contact that cells want to make with the lining. The shear force is so high it'll just basically strip them off, and the cells are basically, according to this notion, the cells are all distributed basically in the center. The cells are all distributed in the center. Now if you think back to what I said in the previous panel, because of the changes in the viscosity and the changes because of the changes in the viscosity and that whole notion of stasis or rubor, the flow rate in inflammation, so think of this as the non-inflamed, in the inflamed state, the flow rate drops. And because the flow rate drops, the absolute shear stress at the wall is actually less. And so what that does is it causes somewhat of a redistribution. So now, even though most of the cells still abound in the center, there is more cells at the periphery just because the shear stress is less because of the lower flow rate. And if you look at transparent vessels, you actually see that. And that physical force alone is what's responsible for the process of margination. So margination is just simply physics. There's no chemistry going on yet. So just to say this again, and this is all you need to know, margination is a redistribution in the spatial distribution of your cells that's caused just by the fluid flow properties that's allowed by the lower shear stress of a lower flow rate, which is in turn caused by the stasis of inflammation. So talking about our next two phases, in the attachment of the leukocytes, it is the phase that we called rolling and then adhesion. So imagine this is a white blood cell, and the white blood cell is flowing through the vessel. But it's now going to flow a little slower because of the stasis, and then imagine there's a receptor. But the receptor doesn't bind it very strongly. So it sort of bounces around, and then it keeps flowing, and it flows out. And the reason for that is because the binding constant of the leukocyte, which I'm showing here in white, this white ball, the binding constant of the leukocyte to the receptors that I'm showing in purple are not sufficiently strong to totally overcome the shear force of the flow. So we have two competing forces. We have two competing forces. And our two competing forces are the binding constant between the leukocyte, which we could show here, the binding constant between the leukocyte and the receptor, and that's one force that pushes for adhesion, but then you also have the flow rate. And if the binding constant isn't sufficient to overcome the flow rate, then you get a rolling phenomenon. However, now imagine that the leukocyte is going along, and then it hits a receptor with a very high affinity. And imagine that the affinity is almost enough, or maybe even enough, to overcome the flow rate. So imagine it's almost enough. So it hits the receptor, and it's almost bound, but then the flow rate shears it off, but now it's going much slower, and now it's bound and it sticks. So if the binding constant is significantly higher, then with that higher binding constant, then you could actually get true adhesion. So in this model, the difference between rolling and actual adhesion is the difference between how much the binding of a given receptor on the endothelium binding to the leukocyte is able to offset the forward shear stress. If it can't overcome it, then you get this sort of rolling phenomenon, but if it can overcome it, then you get binding. So in the last part, we'll just discuss the rolling phase and the adhesion phase. Obviously, the rolling phase then will be a phase where the endothelium elaborates low affinity receptors that can sort of stave the leukocyte on its way but not overcome the shear force. And then in adhesion, then the endothelial cells, as the vessel lining cells, upregulate or express very high affinity proteins that could not only slow down the leukocytes, but that it could actually overcome the shear stress of the forward flow. So it'll just be a matter of different proteins being expressed by the endothelium and by the leukocyte. So to go into a little bit more detail, the rolling phase involves the binding to molecules called selectins that are present on the endothelium, and the upregulation or expression of these molecules that then bind to glycoproteins on the leukocyte surface. So we could call this rolling phase, biochemistry of this, we could call it searching for sugar moiety, just in case any of you saw that beautiful documentary movie, Searching for Sugar Man. So, this phase is searching for sugar moiety. And what I mean by that is selectins are molecules that bind to sugars that are bound to proteins, and sugars bound to, so imagine this yellow line is a protein, and then these pieces coming off are sugars, and we call that a glycoprotein. And these glycoproteins, part of the sugar moieties, bind to these molecules called selectins that are sitting on top of the membrane of the endothelium, but they bind with a rather low affinity, and it's not enough to overcome the shear stress, but it causes a rolling. So sugar moiety, just like Sugarman, causes a rocking and a rolling. And the endothelium wants to express, in the context of inflammation, wants to express these various selectins to begin the rolling process. And very nicely, Robbins points out two models or two mechanisms whereby these selectins could be expressed on the surface of the endothelium. So certain mediators like thromboxane, which is, just in case you want to know, an arachidonic acid metabolite, or histamine, which is really a small molecule that's released by granules of basophils and mast cells. What they do is, there are these pre-packaged P-selectins in these little membrane-bound vesicles within the endothelium that are called Weibel-Palade bodies. And the histamine and thromboxane says, hey, Weibel-Palade body, release your P-selectin to the surface. And that's how P-selectin gets expressed in the context of inflammation. So these factors, histamine and thromboxane, make the pre-formed P-selectins be expressed on the surface, or be transported, rather, to the surface. And then another mechanism is that in the context of the battleground of inflammation, you get these soluble mediators called IL-1, interleukin-1, and TNF, and that actually tells the endothelial cell not to transport anything, but these work through transcription. So there's actually new production of new proteins, so transcription and translation. So there's actually upregulations of genes, and one of the genes is the E-selectin, so another thing that's looking for the sugar moiety, and this is more sort of like a protein synthesis or a production dependent, although the time kinetics suggests that there's other ways that it could happen too. But this one, the P-selectin, is clearly a transport. It's not transcription, it's just transport of prepackaged. But that's details. But the details are quite nice. But the bottom line is that you get upregulation of these selectin molecules on the endothelium. The selectin, and selectin, it sounds like something that should bind a sugar. Lectin, selectin. So these selectins are looking to bind sugar molecules, and they're searching for sugar moiety. And the sugar moieties are indeed expressed on the glycoproteins of the leukocytes. But it's not a very strong attraction between the glycoproteins and the selectins, but there's enough of attraction to get some rolling going. So you could just hear these selectins, singing out, sugar moiety, can you bind me? I need 2 diapedes. Okay, so I'll stop being silly, but we'll now speak about the next phase, which is now the actual adhesion phase. So how do you get that really tight binding? So now let's very briefly touch on high affinity binding, or the adhesion phase. And that involves molecule binding between something called an integrin, which is a certain class of family of molecule on the leukocyte, and these molecules called CAMs, cellular adhesion molecules on the endothelium. And basically, normally leukocytes, the integrins, are in a low affinity state, and something happens in the context of the mediators of inflammation that switches the integrins to this high affinity state. So you see the integrin sort of changes its configuration, and then it binds with high affinity to the CAMs, and that's what overcomes the shear stress, and this is the high affinity state. It's a switching of the integrin from the high affinity state to the low affinity state. And that's really the magical thing that causes the adhesion. So that's a very important step, this high affinity integrin binding. And just to take you to a slightly higher level of granularity, just because it's pretty, that Robbins points out, what causes the integrins to go to this higher affinity state is that various chemokines, various soluble factors, work on a proteoglycan. It's sort of like a mucus-like substance that sits on top of the endothelial cells. You could think in the vessel it sort of sits here. So in our microscopic picture, it's sort of sitting here like this mesh on top of the endothelial cells. And one of them is, for example, called heparan sulfate. And so these chemokines modify these mucus-like substance that we call proteoglycans, and they bind to receptors on the overlying leukocyte. Like one of these receptors is called CD44. So the CD44 bind to these modified proteoglycans So different than glycoprotein. Glycoprotein is mainly protein with a little bit of sugar. Proteoglycans are mainly glycans, mainly sugars with only a little bit of protein. And they go by names like heparan sulfate, keratan sulfate, etc. And that's really not the point here. But the only point that I want to make is that chemokines, like, for example, interleukins and stuff, act on these proteoglycans, this mucus-like substance that sits on top of the endothelium, and that binds adhesion molecules on the leukocytes, such as CD34, and that's what causes the integrin shift. It activates, it puts like a charge into not an electrical charge, but it sort of puts the leukocyte, puts the white blood cell into a more activated state. And one of the things that it does is it starts producing these higher affinity integrins that then could bind the CAMs. So that last detail is granular. You don't really need to know it, but the story is a bit pretty. And it also shows all the different families of receptors that are involved in the story. So we spoke about the sugar receptors, the lectins. We spoke about the immunoglobulin family of receptors, the CAMs. We spoke about another family of receptors, and I'm not bothering to distinguish which cell they are, called the integrins. And then we also spoke about molecules like CD44 that bind these glycoproteins. So, because it'll come up in lecture that, somebody might ask, name the different families of proteins that are involved in the story of leukocyte adhesion. So that's basically what I wanted to go through today. So the various phases of attachment of leukocytes and adhesion to the vessel to overcome the shear stress of the fluid. I hope you enjoyed this.